Monday, 1 p.m., and it's time for Mostly Learning's BRAINCAST. My name is Pospo, and I want to publicly apologize, as last week I said summer is here, and the only thing that certainly wasn't here last week was summer. Okay, yesterday was lovely, but still. Last week, we welcomed Dr. Lada Smith and walked down the dark paths of systemic racism and racial trauma, while also exploring the complexities of adequately addressing the nuances of distinct minority populations in research. This week, we visit the vast expanses of psychotherapy, and more specifically, cognitive behavioral therapy, CBT for short. With me, most probably the most appropriate person for this, Professor Trudie Chalder, a professor of, you guessed it right, cognitive behavioral therapy, with a solid 30-year experience in the field of functional somatic syndromes. She develops cognitive behavioral models for not only understanding, but also treating and consequently improving people's lives. Welcome, Trudie. Thank you so much.
Thank you.
So, Trudie, let's start with the basics. You are a professor of cognitive behavioral therapy. So, for people not really familiar with what CBT is all about, can you please share what are the core tenets of CBT?
Well, put in a nutshell, CBT is characterized by behavior and cognition. So how people think and what they do is all important in determining what happens to their symptoms. So by changing or modifying a little bit the way in which you respond to your internal states, such as symptoms or distress, by making some modifications to how you respond to those things, then you can change the experience itself. And it really is CBT. It's very practical. It very much focuses generally on the here and now and helps people to live the life that they would really like to lead. So it's all done collaboratively, and it's a conversation.
Okay, I mean, to be honest, it sounds like really pretty straightforward. So how different is it, for example, from the stereotype that people have of, a person having psychotherapy while lying down on the sofa talking to the therapist? Is CBT like that?
We don't ask people to lie down on the couch. It's not that kind of psychotherapy. It's very much sitting in usually it used to be sitting in a chair opposite somebody, but of course now it's often done on the telephone, or it's done via a webinar or something like that. Not a webinar, the video conferencing, and people talk to each other, and everything is negotiated, and you talk about what the difficulties are, and then you negotiate together about how you move forward. And using very practical approaches. But it's not true to say that it's not just about the here and now. It also does look at how these things began, but using a slightly different language to psychoanalysis. So you might look at the influence of your early childhood experiences and how they've influenced the way in which you think in the here and now. So you would make those links and try and help people to understand maybe why they think in particular ways, and then you would help them to maybe think about things differently, depending on the type of CBT you're doing. I mean, now we have so many types of psychotherapy, it's difficult really to give you a broad definition, but that's essentially CBT in a nutshell. Sometimes you ask people to think about what their thoughts are and come up with alternative ways of thinking, but sometimes you ask people to just sit with their thoughts and notice what they're doing without actually changing them, and that's the more mindfulness-based approaches.
I mean, it's really interesting that, you mentioned about, the here and now. And although you said clearly that, sometimes, we may look into, past experiences, some of the criticisms that CBT has, faced throughout the years is that for some people, it doesn't deal enough with the past. One could say that it sounds like, we're brushing things under the carpet. So what do you have to say on that?
Well, one, I would say that that's not true, that CBT doesn't do that. I think, again, it would depend on the type of CBT. CBT is just a very broad church, and different types of CBT will do different things. I don't think anybody would think that dialectical behaviour therapy was superficial. It's quite complex. There are some treatments, obviously, that are more focused on behaviour change, such as behavioural activation, but then there are other types of CBT, like schema-focused CBT, which is very much focusing on some of the beliefs that people have developed in childhood and where they've come from, and then thinking about how they're influencing things now. So I think that it can be extremely complex, and I also think that even if you're doing something what seems like on the face of it quite straightforward, such as behavioral activation, it can be quite complex in terms of delivering it, because just because you're doing something that sounds quite technical, it doesn't mean to say that all of those relationship factors are ignored, such as warmth and empathy and kindness, which I think run through hopefully all of the psychotherapies.
So thank you for mentioning actually that, there are various different types, because, the truth is that despite the criticisms that, CBT has managed to become the mainstay for the treatment of several psychiatric disorders, from anxiety, depression, OCD, but also more complex presentations like medical unexplained symptoms. So it sounds to me that it's not a one-size-fits-all approach. And so there are differences between the various approaches. I mean, can you tell us a few so that people can understand that, it's not just one thing?
Yeah, well, obviously there's the different types of psychotherapy that I've just mentioned, or different types of CBT. But there are some, I suppose, lots of the therapies have things in common, but they also have things that distinguish them. So I think now people are working more towards a more process-focused approach, which means that you're targeting psychological or behavioural processes which may be common to lots of different problems. So you may have avoidance behaviour, for example, which may be important in depression. You may also have avoidance behaviour that is very key in understanding anxiety disorders. At the same time, you might have a kind of avoidance or reduction in activities that's associated with having somatic symptoms. So in that way, there are some similarities, but obviously the beliefs that people have and their perceptions that might be blocking them from moving forward, they may be quite idiosyncratic and differ according to the problem that the person's presenting with. And I think any good assessing clinician, whether you happen to be a CBT therapist or a psychiatrist, would be wanting to get to the nub of the matter. So what's the devil is in the detail. What kinds of thoughts are people having, and how are they influencing what they're doing or not doing? What is it that's stopping them from living the life that they want to lead and which they value?
Oh, what is it? What is it? So one of the challenges.
I think we could all ask ourselves that question. Exactly. But I think that's, Go on. No, I was just going to say that I think psychotherapy isn't something that just can be done to, or provided for people who have got big problems. It can also be useful for people who are just struggling with finding out what they want to do, or, where they're heading in life. And, I think people have been thinking a lot about that more recently because they've had a bit of time on their hands.
I mean, Trudie, one of the challenges, though, of measuring talking therapist outcome, like meaning, does it work or does it not work, is standardization. So how can you standardize a talking therapy? It sounds to me really difficult.
Well, I suppose it's you can standardize it within reason, and there are lots of ways of standardizing psychotherapy. So whether it be CBT or another kind of psychotherapy, first of all, you would want it to be based on a theory, and hopefully the theory will drive the components of the intervention, which you can then evaluate properly in a randomized controlled trial, and you can then see whether the processes that you've been targeted have been the active ingredients through mediation analysis. But largely you would need to have a written manual for the therapist and the patient. You can have good supervision for the therapists who are providing the therapy. You would want to list, in order to really assess whether the therapy is doing what the therapist is doing what they're supposed to do, is that you would have to listen to recordings of their therapy, obviously with the patient's permission. And then you would be able to rate the content of the therapy to see whether it indeed is CBT and not psychoanalysis or whatever. So there are a whole range of different things that you can do to assess whether it truly is what you're wanting it to be.
I mean, okay, I'm not saying that it sounds easy, but if it's feasible to actually standardize, so then why don't we train, more people to deliver CBT? So is this what you were thinking with the Prince trial? Can you tell us a bit more about that?
Yeah, well, just to answer the first question, which is training lots of different people, I think that's what the IAP services have been set up to do. Because obviously when I started in CBT 30 years ago, there weren't very many CBT therapists around. I was extremely fortunate and training with Isaac Marks, who I thought was a brilliant teacher. But subsequently, of course, David Clark set up the IAP services, and where CBT is now being, and different types of evidence-based psychotherapy are being delivered to people all over England. In the Prince trial, we were focusing on people who have a number of different somatic symptoms. So whether it be fatigue or pain or bowel symptoms or functional neurological symptoms. And we were really targeting the transdiagnostic processes. So the things that people having, the processes that people have in common. And even though they could still alter the therapy a little bit depending on the needs of the individual, because obviously it's all based on the individualized formulation of the problem, it was targeting some common processes.
So now you have a specific interest in psychotherapeutic interventions for functional neurological disorders, so FND for short. So can you give us a definition of, I know it's difficult, of what FND is? I know, it's really challenging. But can you try at least to give us a definition of what FND is and what some of the really serious difficulties this cohort of patients are facing?
Yeah. Well, I think in a nutshell, people are experiencing physical symptoms with no clear-cut organic pathology, but they do have something that's wrong with their functioning, if that makes sense. So there may be some physiological difficulties that are things are not going and working in the way that they should work, that are really producing or maintaining these physical symptoms. So there are physiological mechanisms maintaining the symptoms, but there wouldn't be an organic pathology such as an inflamed organ that you can address specifically like you would with a very clearly defined medical disease. But these symptoms really affect people profoundly. They make the individual very anxious because they don't know how to manage them. That would probably be true to say that it doesn't just affect the patient in that way, but it also can make health professionals quite anxious. But it also can lead to quite profound disability. So people are not able to carry out their everyday lives in the way that they would like to. And so the symptoms can be very varied, seemingly quite simple symptoms ranging to quite complex ones where people can't move a limb or something like that.
I mean, you're right. It sounds like it's an umbrella term that,
yes.
different presentations, yeah.
But they are very, very common. And I think it's probably true to say that it's the second most common symptom or problem and diagnosis that the neurologists see in the neurology outpatient clinic. And of course, these patients often get admitted too. So what's also quite worrying is that these difficulties are given so little attention in medical education. And I think that does need to be addressed, given how common these symptoms are both in hospital populations and in primary care. I think the patients have had a disservice in the past because they haven't enough investment hasn't gone into them.
Yeah. I mean, most recently you led an all-star team, including Professor Laura Goldstein, and you ran the largest trial. I mean, I remember, being a junior doctor at the Lischman back in 2011, and people were already talking about this massive trial called CODES. Right. So, number one, so why did it take so long? We have 2020. Don't get me wrong, I am aware that this is a massive endeavor to undertake, but I think it would be, really interesting to hear the specific hurdles that the team had to overcome to make such a big trial happen.
Well, first of all, I'd like to say that it was led very ably by Professor Laura Goldstein, who's a neuropsychologist. And she brought together a huge team from England, Scotland and Wales, which I thought was no mean feat. It was a huge undertaking, recruiting patients from England, Scotland and Wales, as I say, and it involved neurologists, psychiatrists, psychologists. It was truly a multidisciplinary team who took part. People were recruited from neurology outpatients, and the patients were initially assessed by neurologists and then psychiatrists before a proportion of them were randomized, and half of them got CBT, as well as the quite sophisticated care pathway that was delivered by the neurology and psychiatry teams. So I think these big trials are always a serious undertaking. They probably age one significantly. I'm now quite grey as a result of several trials I've been involved with over the years. And I think if you ask Laura, she'd probably say that there's something similar, that they are incredibly onerous. The difficulty is recruiting patients who want to be randomised. Then you've got the difficulty of following sufficient number of people up. You then have to deliver a treatment that is has some integrity, so the treatment that you're delivering is what you thought it was going to be. And then you have to write up the results and the many papers and get them published. And it's a difficult job, I would say, not for the faint-hearted.
And people that don't really know, what codes is. So what does it stand for?
Oh my God! Now you're asking. I can't remember the acronym. If you ask me to spell out any acronym, I'd never be able to tell you, because that's the problem. Now you remember codes, but you don't remember what it stands for. Something about dissociative seizures, but I have no idea. You can all look it up on the paper. So
yes, so it was CBT for adults with dissociative seizures.
Yes.
And it was, as you said, it was a multi-center and randomized controlled trial. And it seems that, on one hand, you had, the, let's say, treatment as usual, right? And then on the other hand...
Yeah, just to interrupt you, that wasn't treatment as usual. It was standardized medical care.
Standardized, fantastic.
Yeah, standardized, and I think that's probably really important to emphasize, because the care pathway was quite sophisticated and it was standardized as opposed to standard medical care. So half the people were randomized to standardized medical care and the other half got the standardized medical care plus the CBT.
And can you take us through the results?
So the primary outcome, which was seizure frequency, we didn't find any difference between the two groups, and that may well be because the standardized medical care was pretty good, actually. It could be for all sorts of reasons, but I think the standardized medical care was, as I say, to a high standard. And then in terms of the secondary outcomes, we found that the seizures were less bothersome in the CBT group. They also had a longer period of time with no seizures than the standardized medical care group. The CBT group combined with the standardized medical care also reported better quality of life, and they had better psychosocial functioning. There were one or two other secondary outcomes that were superior. So complicated to interpret. I mean, obviously the primary outcome wasn't that we showed no difference between the groups, but there were quite a few important secondaries where we did find a difference.
That's really important, I mean, showing that actually you have an intervention that can improve people's lives, so that the function and the well-being. I think it's really important. Interestingly, though, the history of functional neurological disorders goes all the way back to my direct ancestors.
Yes.
Well, they did describe similar symptoms. They used to call it hysteria back then.
They did.
But, fast forward a couple thousand years, and we find big moves. Now, Freud has a specific interest in functional disorders, and he talked about repression, about conversion, and in fact, for many years, right or wrong, functional neurological disorders were indeed called conversion disorders. Now, we all know that Freud was the father, mother, and aunt of psychoanalysis. So how do you think, I know it's a really hypothetical question, how do you think he would react if he saw that you are trying to treat his conversion disorders without really touching on the conversion aspect, without psychoanalysis?
Well, first of all, I think Freud was a very clever man, and he gave us a language that we're still using to this day. So he has to be congratulated for that, doesn't he? But I think also he's probably a man that would have moved with the times, to be honest.
Yeah.
So I think things have moved dramatically. And I think a lot of his theory, if you like, and his mechanisms are still important to this day. But I think probably what's happened is the language that we're using has changed. So I think we're still interested in what happens if you don't acknowledge your emotions, which might be called suppression. We're still interested in what happens if people don't give themselves permission to talk about their emotions. We're still living in a time which may be not too dissimilar to his, although I think it's changing somewhat, where when very, very difficult, distressing, traumatic things happen to us, there often is shame attached to it on the part of the individual who is the person who was on the receiving end of that. So I think in that sense, it's probably quite similar with the stigma and the shame. Not everybody, obviously, with dissociative seizures has a traumatic background, but for a fairly sizable percentage, about a third, they do. So I think a lot of things haven't changed dramatically. The context probably hasn't changed, but the language has probably changed. We certainly know, in terms of CBT, we know that there's been lots of experimental studies showing that if you don't express your emotions, it can make the symptoms worse, and that's probably because people are more inwardly focused, and we know that the more you focus on something, the more it magnifies it, and that would be in any branch of psychology. Where were we? You've lost me. I've lost myself.
That's beautiful. That's beautiful. Losing yourself. But it's because we mentioned that language is so important.
Yeah.
And sometimes I see how we're talking about the same thing throughout time, but in different language.
Yes,
so you see that the same concept, so the same disorder has so many different names, throughout the years. And what I find interesting is that patients themselves, they choose what suits them best, what they feel they can understand, they can describe, better what they're going through, and that's fine. Yeah.
And I think also, if you think about it, medicine is hopefully becoming less dualistic. In the past, if you had something physically wrong with you, it was real. But if you have some psychological difficulties, somehow people thought it was made up. And I think when we're thinking about functional problems, the DSM has really changed the way it categorizes these problems and is now using the term somatic symptom disorder, which it's very controversial, but I really like it. I like it because the same model can be applied irrespective of the cause of the symptom. So whether you've got pain or fatigue related to an inflammatory condition or a functional symptom, then some of the mechanisms may well be similar, in that the way in which we interpret things, the attention we give to the symptoms, and the way in which we respond behaviorally could be all important in determining the outcome.
Now, you mentioned fatigue, and it's one of your interests. It would be impossible to cover all your interests. You have like more than 300 papers, but fatigue. Now, most people link fatigue to tiredness. So what does fatigue have to do with psychology? How can you improve fatigue with CBT?
Well, first of all, CBT can be useful for people irrespective of what the symptom is. So as we were talking about earlier, the way in which we respond to symptoms in terms of what we do in response to them and the way in which we perceive them, that's all important in determining the outcome. So of course, the approach that you use is going to be similar. So CBT can be very useful for treating the responses to the symptom of fatigue. Like you could use CBT for chronic pain, chronic fatigue, bowel symptoms, all sorts of symptoms, because you're targeting people's behavioural and cognitive responses as opposed to the symptom itself. And of course, if you target those responses, then the symptom itself can change in the same way that distress might change or anxiety might change. Symptoms do change when you do something different in response to them. It's not that we're saying that it disappears, the symptom will disappear altogether, but the strength of it the volume can be turned down, and that's important.
Fascinating. It's really interesting. I mean, although, every time, I say that, don't mention the pandemic, don't mention the pandemic, but it's still happening. So I'm really curious to see how psychologists, have been dealing with the pandemic. So are there any difficulties in delivering, CBT, which, it is a practical, we would say, psychotherapy? Do they have difficulties in remotely delivering it, or is it even preferable to the old way?
Yeah, well, it's interesting. I think different strokes for different folks, but we did a trial where we compared face-to-face and telephone treatment, and we found that there was no difference for chronic fatigue syndrome. We've been delivering psychotherapy within our service, within the South London and Maudsley NHS Trust, over the telephone, sometimes via Teams, a platform such as this, and patients have said that they've found it just as helpful. On the other hand, I think there will be some individuals who prefer to see somebody face-to-face in the same room, but largely speaking, the results seem to be pretty promising.
Wow. Okay. So, and what are you working on currently? Do you have any projects that we can,
Yes. Well, I'm working on a big trial with Queen Mary's, where we're recruiting people and from cohorts of people who've had cancer, who've had treatment for cancer, and they've been treated with curative intent. And we've been developing an ACT-based intervention to help people deal with the symptoms and the difficulties with their functioning after they've had a course of treatment for cancer. That's an NIHR funded program grant. I'm also collaborating with Notting, with Cav Fatara, who's leading a program on diabetic foot ulcers. So we've developed a treatment for men, primarily men, but women as well, who've had diabetic foot ulcers, and they're very distressed. And so we're at the early stages of that as well. Both of them, of course, delivering psychological interventions or behavioural interventions for people who've got physical diseases, who are experiencing disability associated with the symptoms, and a lot of distress and extreme symptoms. So obviously watch this space. We don't quite know where they're going to land yet, but we'll see. Both of them involve randomized controlled trials, but we haven't started those yet. One of them was delayed somewhat because of the pandemic.
Thank you so much, Trudie. That was cognitively and behaviorally illuminating. Next week, leave CBT cycles and cognitive distortions and delve into the depths of an extremely important yet surprisingly underfunded field of psychiatry: addictions. With me, Dr. Emmett Roberts, an extremely captivating and passionate speaker and clinical lead for the innovative homeless hotel, drug and alcohol support service. Yes, we will touch on the effect of the pandemic on alcohol use. I mean, how could we not? See you next Monday at 1 p.m. I know I need a haircut. It will happen soon, I promise. Pospo and BRAINCAST for Maudsley Learning, over and out.
Thank you very much.
You're welcome.